everyone, Dr. Suresh here, Professor of Biochemistry. As a part of our FMGE case-based test series for this session July 2023, I have come up with another case-based question related to the lipoprotein metabolism. So, if you are concerned about the disorders of lipoprotein metabolism like types like hyperlipoproteinemia, hypolipoproteinemia. So, to know the difference between these two and to analyze in better way, we should go through with a proper case basis scenario. So, here first I will be dealing with one question, that is hyperlipoproteinemia, right. So, the answer I am telling in the beginning itself. So, this is the case related to hyperlipoprotein, but there are sub classifications are there regarding the hyperlipoproteinemias, right. So, that we will see in detail in further slides. So, first if you see the stem of the case, a 40-year-old male, he is old male, 40 year, visited the clinic with occasional chest pain and shortness of breath on climbing stairs. He reported that his father died from heart attack at age of 46. So, family history reveals that the death of the generation is heart attack, and elder brother also had heart attack at the same age, but survived and was on medication for elevated cholesterol, right. The patient had no history of diabetes and hypertension. On examination, multiple xanthomas were found. So, xanthomas are nothing but abruptive lipid depositions over the skin, were found over elbow, fingers, Achilles tendon and buttocks. So, the cardiovascular and other system examinations were normal. RBC, thyroid function test, kidney function test, liver functions were also normal. The lipid profile data was as follows. If you see the normal levels, so that is importance of remembering the normal levels of certain markers, like suppose liver parameter, if you say ALT, AST, cardiac markers, LDH, creatine kinase, cardiac troponins, right. So, certain markers are, it is mandatory to know their normal values, right. So, serum cholesterol you see here 430 milligrams per deciliter, it is too high, and TAG 80 milligrams per deciliter, it is too low, and LDL 380 milligrams per deciliter again, and HDL again it is low. So, here total cholesterol is comprised of both LDL and HDL. So, the normal levels, if you are aware, you can easily sort it out, okay, and normal triacylglycerol levels like 250 to 300, which is supposed to be, which is very low. So, the physician prescribed medication which is stated was directed at the rate to inhibit some like pathway like cholesterol synthesis. So, the rate limiting step of cholesterol synthesis HMG CoA synthase. So, that will be targeted by the drug statins in the cholesterol biosynthesis. So, here this is a familial hypercholesterolemia because cholesterol levels are high. So, this is a scenario related to hypercholesterolemia, and that too what subcategory, you can say type 2A hyperlipoproteinemia. So, this is a case because there are different types of lipids are there. Triacylglycerols, triglycerides are one type of lipids, LDL is one type of lipid like HDL, and lipoproteins also there. So, based on the type of the lipoprotein elevated or lipid elevated, the lipid storage disorder you can make out such as familial hypercholesterolemia, and that too which part of lipids are elevated, cholesterol levels. So, type 2A, and which type of cholesterol, that too LDL. So, this particular disease belongs to type 2A hyperlipoproteinemia. So, we will see the subclassification of different hyperlipoproteinemias. So, here the person Fredrickson, he was the one who categorized these hyperlipoproteinemias. So, what are the types are there? So, first one is familial hyperlipoproteinemia. In this familial hyperlipoproteinemia, it is the first type, there will be increased triglyceride. The case what we have seen in this, there is increased levels of total cholesterol, that to LDL part, okay, but TG levels are decreased. So, it is not a type 1 familial hyperlipoproteinemia. And familial hypercholesterolemia 2A, there are types are there, familial hypercholesterolemia 1, I mean A and B. So, familial hypercholesterolemia 2A, here total cholesterol levels will be increased, only total cholesterol, that to LDL cholesterol. In 2B, familial combined hyperlipoproteinemia, where total cholesterol and triglyceride levels both will be elevated. First, familial hyperlipoproteinemia, where triglycerides levels alone increased. In case of Second, that is familial hypercholesterolemia, where only total cholesterol levels will be elevated. In case of familial combined hyperlipoproteinemia, both total cholesterol and triglyceride level will be elevated. In case of third one, familial dis-beta lipoproteinemia, again total cholesterol and triglyceride levels will be elevated. And fourth one, familial hypertriglyceridemia, only triglycerides level will be elevated. With the name itself indicative, hypertriglyceridemia, hypercholesterolemia, right? So hypercholesterolemia, total cholesterol will be elevated. Hypertriglyceridemia, triglyceride levels will be elevated, right? So mixed hypertriglyceridemia, both total cholesterol and triglyceride level will be elevated. So this is the Fredrickson classification. That means Fredrickson approved, like WHO approved classification for hyperlipoproteinemias. So now we will see one by one in detail. So type 1 hyperlipoproteinemia are familiar lipoprotein lipase deficiency. So here the main deficiency thing is here is lipoprotein lipase, otherwise ApoC2. This is activator of lipoprotein lipase. So in absence of ApoC2 protein on the chylomicrons, lipoprotein lipase cannot be activated. So the triglycerides which are present in the chylomicron, which will not be catalyzed, and there is accumulation of triglyceride in chylomicrons and in the certain tissues, leads to type 1 familial hyperlipoproteinemia, where triglyceride levels you can see. You see here there is a absence of ApoC2, so that lipoprotein lipase cannot work. So triglycerides cannot be catalyzed from chylomicron into the tissues such as muscles as well as adipose tissue. So there is no conversion of glycerol and fatty acids in the circulation as well. So you can say hardly there is no free fatty acid levels in the circulation. So the consequences in type 1 hyperlipoproteinemia, increased TAG levels. So if you see, if you collect the person sample, person who is suffering with familial lipoprotein lipase deficiency or type 1 hyperlipoproteinemia, their plasma will be, if you see, it is like white milk type. Okay, so thick cholesterol type you can see in the sample. So total cholesterol usually normal. So normal or decreased LDL or HDL you can also make out. So as I said in the case, so eruptive xanthomas. So because of these hypoglycemias, they start these chylomicrons loaded with triglycerides started accumulating in the soft tissues, leads to eruptive xanthomas, leads to pancreatitis, but there is no atherosclerosis because the type of lipid here accumulating, that is triglycerides, not the cholesterol. So here what is the treatment for this? Dietary fat restriction supposed to be like minimal 15 grams per day you have to restrict, and fat soluble vitamin supplementation which aids the metabolism of chylomicrons, and small and medium chain fatty acid consumption has to be there, avoiding directly triglyceride content. So now, so here increase the TAG greater than 500 milligrams per deciliter in spite of dietary and lifestyle modifications, then fibrates and niacins are given. So here this is one more consideration here in treatment. If triglyceride levels are more than 500 milligrams per deciliter, in spite of your diet regulations and lifestyle modifications, so fibrates and niacins which will inhibit the fatty acid absorption or triglyceride absorption from the intestine. Next one is type 2A familial hypercholesterolemia. So here the main thing is the name itself indicative, hypercholesterolemia, the type of cholesterol elevated in the circulation, that is LDL. Okay, so here the metabolism related LDL will be defective. So because if LDL is carrying cholesterol from liver to peripheral tissues, when it reaches to the tissues, the tissue membrane has to accept the LDL by recognizing the receptor on the LDL. If LDL is not having the receptor, because these receptors are nothing but proteins, so when these receptors are defective in synthesis, LDL cannot be recognized by the tissues and LDL cannot donate or drop off its cholesterol circulation to the tissues. So that is why LDL start accumulates in the circulation and it undergo oxidation to form foam cells, leads to atherosclerosis, blockage to the circulation, and if it happening in the cardiac arteries, then it leads to atherosclerosis. So here these clathrin coated pits on the tissues cannot they will recognize only the LDL receptors. So if LDL receptors are not there, clathrin coated pits cannot recognize the LDL receptors. So LDL receptor defect, first main thing, the reason for familial hypercholesterolemia type 2A. LDL receptor defect. ApoB defect, increased activity of protease that degrades LDL receptor, and here PCSK9 proprotein convertase, subtilisin, kexin type 9 drugs also, which inhibits the formation of LDL receptors. So as cholesterol will not go enter inside, it will be like high levels of cholesterol you can make in the circulation, and that too in LDL, which undergoes oxidation to form foam cells. So what are the again further characteristics of type 2A familial hypercholesterolemia? It is autosomal dominant. Remember, type 2A familial hypercholesterolemia, autosomal dominant. That's the reason. Family history. If you see the case details that we discussed in the beginning, so father already died because of the heart stroke, and brother also suffered the heart stroke, but he survived and he is on medication. So this person also used to get chest pain at times. So that means this is genetical. This LDL receptor protein synthesis deficiency is genetical. It runs in the families in generations. So that's why it is autosomal dominant. So characteristic feature, as we mentioned, there is increase in total cholesterol, increase in LDL type of cholesterol, and TAG levels, triglyceride levels are normal. So otherwise decrease in HDL content. Tendon tuberous xanthomas, yes, again as we have seen in type 1, atherosclerosis is early onset, is a dangerous one. So diagnosis, positive family history, first degree relative diagnosed with the premature cardiac artery diseases, presence of xanthoma, positive genetic testing for LDL receptor defect, high LDL, that means greater than 90 percentile for age for sex. So early diagnosis, you see cardiac arteries are getting like blocked because of the foam cell formation, and xanthomas you can make out in the tendons, and corneal arcus also you can see. So what is the treatment for this? You can make out low cholesterol diet, decreased intake of saturated fat, and administration of PUFA also improves the situation. Statins especially, which blocks the cholesterol synthesis, simvastatin, atorvastatin, bile acid subsequent, which aids the lipid absorption, histamine inhibit cholesterol absorption, and PCSK9 inhibitors like monoclonal antibodies, evolocumab and alirocumab are the drugs which can treat this type 2 hypercholesterolemia. So now we will see overall, like we'll see later. First we'll see type 3 familial dis beta lipoproteinemia. This dis beta lipoproteinemia because of the defect, ApoE defect. So here the ApoE is one of the membrane protein for chylomicrons. So what happened, this ApoE is responsible for chylomicron intake into the liver. As ApoE is not there, chylomicron remnant will not be entering into the liver, and it will be in the circulation. So result of that, there will be increase in total cholesterol concentration as well as triglyceride concentration, increase in IDL. That means when chylomicrons will be converted into, VLDL has to be converted into LDL, so IDL formation. So decreased LDL formation you can make out, normal HDL levels, Palmer and tuberoeruptive xanthomas also you can note down. Atherosclerosis, again one of the prominent feature of this familial dis beta lipoproteinemia. So here green color one is ApoE receptor. So yellow one is a LDL receptor, and LDL receptor related protein you can also make out here. The pictures, if you see the eruptive xanthomas and Palmer eruptive xanthomas also you can see on the hands, palms. So hypolipoproteinemia, like due to reduced synthesis of proteins like A beta lipoproteinemia and Tangiers disease. These are two prominent disorders related to the A beta hypolipoproteinemia. Hypo, so far we have learned about hyper. Now hypolipoproteinemias, two things are there, A beta lipoproteinemia and Tangiers disease. So one we have already discussed, ApoE deficiency. So A beta lipoproteinemia is because of the gene deficiency, that is MTTP gene mutation. Like what is the full form? Microsomal triglyceride transfer protein. So because of absence of this gene, there is no protein synthesis of microsomal triglyceride transfer protein, which is required for hepatic and intestinal assembly of ApoB and lipids. Occurs in the lumen of endoplasmic reticulum, this process, and it is a two-step process. A small amount of lipid is transferred to nascent ApoB, endoplasmic reticulum, to a primordial ApoB particle. Lipid is added to the primordial ApoB particle. And if you see much more details of A beta lipoproteinemia, like it is autosomal recessive, unlike type 2A hypercholesteremia, which is autosomal dominant. Genetic defect in synthesis of ApoB and lipoprotein containing ApoB48, and because ApoB48 and B100 both require, these are the proteins required for chylomicron as well as LDL. Fat metabolism, like fat malabsorption as chylomicron cannot be formed, leads to steatorrhea. Neurological symptoms like vitamin E malabsorption also noted. Ocular symptoms like vitamin A malabsorption, retinitis pigmentosa, vision impairment also you can note down in A beta lipoproteinemia. So here the A beta lipoproteinemia, what are the probable reasons? Deficiency of LDL, decreased total cholesterol and decreased triacylglycerols. And treatment, reduced fat intake is one of the mechanism of action to take, and also vitamin A, D, E, K supplement also improve the situation of A beta lipoproteinemia. So if you see the Tangiers disease, so here the gene ABCA1 is defective, so that there is no efflux of cholesterol and phospholipids, and there is no formation of pre-beta HDL-A1, right? So Tangiers disease is because of the mutation in the gene which codes for ABCA1 protein. Okay, this was the question asked in the last FMGE. Okay, due to mutation of ABCA1 protein, Tangiers disease. So tonsillitis, orange tonsillitis, because of the deposition of cholesterol in the extra hepatic tissues, like in soft tissues. ApoA1 in HDL cannot take up cholesterol from cells that lacks ABCA1. ApoA1 is rapidly removed from blood and destroyed. Very low HDL levels you can note down, okay, because as cholesterol is not efflux into the HDL, and it is a rare disease. So genetical disorder, Tangiers again, and main you have to remember, it is because of the deficiency of the gene ABCA1, okay, which codes for ABCA1 protein, which helps in efflux of cholesterol and phospholipids into HDL. And if you want to compare all the lipoproteinemias, so familial hyperlipoproteinemia, the defect is mainly lipoprotein lipase and ApoC2 deficiency. The accumulated lipid will be like high levels will be triglycerides, and chylomicron levels lipoprotein, because triglyceride is related to chylomicron metabolism. So elevated chylomicron you can see. So what are the symptoms or diseases you can get? Pancreatitis, eruptive xanthoma, but no atherosclerosis as cholesterol is not involved. Familial hypercholesterolemia because of LDL receptor deficiency, ApoB, PCSK9 gene. So total cholesterol level will be elevated and LDL levels also elevated. So tendon, tuberous xanthomas and atherosclerosis. And in 2B familial combined hyperlipoproteinemia, it is a polygenic, both total cholesterol and triglycerides level will be elevated. There is a marked increase in VLDL and LDL levels, and atherosclerosis is a prominent feature of 2B. And familial beta lipoproteinemia, ApoE deficiency, here again both total cholesterol and triglyceride levels are increased levels of ideal intermediate density lipoprotein you can make out. Here in this Palmer tuberoactive xanthoma you can make out, and atherosclerosis also you can note down. And familiar hypertriglyceridemia, ApoA 5 type of protein will be deficient, so increased triglyceride levels, increased VLDL levels leads to pancreatitis. Mixed hypertriglyceridemia, ApoE again, and the gene GP1 HBP1 is the main reason behind of this. Increased total cholesterol and triglyceride levels, increased VLDL and increased chylomicrons. So atherosclerosis is more positive in case of mixed hypertriglyceridemia. So these are all things about the disorders related to lipoprotein metabolism, both hyperlipoproteinemia and hypolipoproteinemia. So hypolipoproteinemia we have already discussed. A beta lipoproteinemia and Tangiers disease are the example for hypolipoproteinemia. For hyperlipoproteinemia, familiar lipoproteinemia because of LPL deficiency, lipoprotein lipase deficiency, where triglycerides will be elevated, and 2A hypercholesterolemia where total cholesterol level will be elevated. Both in 2B triglycerides and total cholesterol both will be elevated in 2B. So that is the difference between hyperlipoproteinemia and hypolipoproteinemia. So that's all about this video. Thanks for watching. Thank you.